Welcome, everybody. Thank you for joining us today. I hope all of you are staying safe and being well during this difficult time. Thank you for joining us today to talk about driving bottom-line revenue by leveraging visual analytics. My name is Scott Everitt. I'm the Vice President of Healthcare Solutions with Practical Data Solutions. I'm joined today by Kelly Constantinetis, Business Intelligence Analyst with PDS.
Hi, Scott. Thanks. And hi, everyone. We do appreciate you taking the time today.
Today, we want to focus on visualization and how visualization can really help organizations manage change and communicate better out to everybody who needs access to information.
So here we're looking at a revenue integrity visualization, and we're tying together different data sets. So we have some denial data, some accounts receivable information, as well as coding distribution data. And this really demonstrates how the technology can be leveraged to get information right at your fingertips in an interactive format. And the goal for today is how to make sense of all this information and ultimately drive more revenue to the bottom line. And that's what Scott and I are going to talk about in today's webinar.
When we talk about the bottom line, what are we really talking about? Well, a lot of times you've got good revenue, but it's tied up in various sections of your revenue cycle. What we want is we want those dollars to actually hit our bank accounts so that it becomes usable to help us grow our organization and do the things that we need to do, provide better care for our patients. Well, if we can tighten up the revenue cycle, all of that money that's tied up all of a sudden starts falling to the bottom line.
I was just going to say, let's talk about some strategies to strengthen the bottom line, and where do we want to start?
Obviously, there are three key ways I think we can start when we talk about moving towards the bottom line. You can see more patients, improve your volume. You can increase your panel size and your market share. You can look at productivity metrics and patient access metrics to make sure you're getting more patients through the door. Really, we'll talk a lot about improving volume. A second way you can do it is by improving reimbursement, getting paid for the services that you do provide, and improving accuracy in what we're doing as far as our charge entry and our coding, minimizing denials, improving the back-end collections and management that we have there, and getting all of the bonuses that we're entitled to through various shared savings contracts. In addition to that, the last thing is that we can get paid faster. We can improve the lags and, again, get that money that's tied up in our processes down to the bottom line through improvement in the various lags that are out there or through the management of our outstanding accounts receivable and turning that into cash.
So, Scott, let's dig into the first strategy you talked about, and that's seeing more patients. How do we translate that into productive growth for the practice?
Well, seeing more patients really kind of starts with the patient access process, scheduling, provider template utilization, things like that, making sure that we're as efficient as we can be so that we're getting as many patients through the door as possible that way. Individually, we can look at referral patterns for our specialists. We can look at community trends and things like that. We can also look at maybe strategic growth through outreach or various opportunities that may come by getting a little bit closer even to where our patients are. So if we look at a visualization, you can see right here a quick visualization that can be turned out even using a tool like Microsoft Excel. And ideally what we're trying to communicate with these visualizations is we're trying to be able to give the end user the ability to digest information very quickly through the use of charts, through the use of trend indicators. And as you can see, say even up in the upper right, you can see use of trend indicators to show year-over-year, month-over-month variances and how they're doing. They can see right away areas where they're doing well or where they're struggling. You can see answers to questions they may have regarding their productivity or scheduling appointments, things like that. They can see right away, I'm doing well in these 5 areas, but I'm struggling in 1. And that's where they can really focus their efforts to try to find improvements. You can look at trends very easily. You can see percentages to make sure those look appropriate, and then highlight just the key measures that are out there, things like patient satisfaction or clinical quality scores. This really helps with the communication, and it makes people actually look at their monthly reports rather than trying to digest a whole bunch of numbers that maybe come in a grid. This is something that I think with the technology that we have these days, you can get even a little bit better as far as the interactability of visualizations?
Scott, here we actually have an interactive dashboard, and we're looking at provider level information, and we're focusing on indicators like productivity, patient satisfaction scores, and charge lags. And we can really start to correlate some of this information and these metrics. So as an example, if we have a provider with a particularly low 99214 distribution, could that also potentially be impacting that provider having a lower work RVU total? And we also bring in some RVU and coding benchmarking numbers to this to add some context to this dashboard. And we can leverage those benchmarks and bring in other thresholds or targets and add visual cues. And that really allows us to quickly do analysis, potentially identify gaps or opportunities. I think a key feature of this visualizing data in general is how quickly we can communicate the information to users.
You know, I think a couple of things stand out to me. One is the very quick red, yellow, green indicators that are out there of where we're doing well, where maybe we're struggling. In addition to that, Kelly, you talked a little bit about benchmarking. And benchmarking is really great for adding context to these measures that we're putting out there of here's where we are, but is that good or is that bad? And how do we compare? And a lot of times we get asked by clients, well, here's where we know where we are, but where should we be? And so let's talk a little bit about benchmarking and how that can be utilized within your practice and visualizing these sorts of things. Benchmarking is really kind of a good key, but it can get a little tricky with how you present it if you don't do it the right way. Let's talk a little bit about the types of benchmarks. There's a self-benchmark, which is just kind of a period-over-period benchmark. A lot of times clients say, well, where should we be? And I like to say, well, you want to be better than where you were a year ago, or a month ago, or a quarter ago. That period over period really kind of gives some context to what you're looking at. In addition to that, there are internal benchmarks where you may be comparing providers or departments or clinics against other peers within the same organization. That can help provide some additional context and really takes out a lot of biases and things like that that may come by doing external benchmarking, which is where you're leveraging information that comes from external organizations that collect a bunch of data so that you're comparing yourself to best practices. External benchmarks are great when you're trying to move your organization to the next level. You just need to be a little bit careful to make sure everything's being calculated the same way. And then what's really kind of coming on now as a trend in the industry is predictive benchmarks, or what could happen, and taking the performance of where you are and modeling that to say, well, what could happen if we were performing at these best practice levels? Presenting benchmarks can get a little bit tricky. And the reason for that is a lot of times people think that this may be embarrassing or punitive. And so the way we like to handle that, or what we say at PDS when people start benchmarking, is generate light, not heat. We're not trying to use this as a punitive measure. We're trying to look at what's going on within the organization. We want to really recognize who are the high performers and how can others kind of emulate their behavior or what they do and model from those best practices. Also, when you look at it, places where you as an organization or even individuals may be underperforming, that's not necessarily a bad thing. It's really more of an opportunity. It's low-hanging fruit, because a lot of times they didn't even know they were underperforming in these areas, and it's just a couple of quick fixes, and it provides a very high return in a quick period of time. So again, utilizing these benchmarks effectively within your organization can really help drive a lot of change that you may be seeing. So let's take a quick look at a visualization that does incorporate benchmarks. This is a model that we call performance opportunity visualizations. And what we're trying to do here is we're trying to leverage the known and utilize a comparison to model what really could happen. So what you're seeing here is we can look at individual providers within a department, and we can see their annual collections. We can see their total clinic visits, and then we can very quickly calculate just kind of an average revenue per visit. Well, we then know also how many sessions they had blocked and how many appointments per session, so that you can see on average the department had about 10.7 clinic visits per session. Well, if each individual provider who is below that could generate the same level as their peers within the department, all of a sudden you can see there are some financial opportunities that arise. So you can look right away at Charles Anderson, the very first one on there, and see if his 8.4 visits per session turned to 10.7, well, that would be a realization of about $22,000 over the course of a year. Okay. Or if you look at Leon Joplin, that translates to about $68,000 over the course of a year. What it does is you're not necessarily going to collect all of this, but what you're doing is attaching a cost of doing business the way that they're doing. It can help you dig in and understand why those numbers look that way. And it highlights the outliers. Who are the 3 or 4 providers that provide the greatest opportunity if you can manage them up to the level of their peers, that would provide the greatest financial return for kind of the lowest amount of effort on the management side of things. So this is just one way that you can kind of leverage both benchmarks and visual techniques in order to really kind of drive change within your practice.
So let's move on to the next key area to drive revenue to the bottom line, and that's maximizing reimbursement. Are there things we can do to improve on the way we're managing our current business? So are there major irregularities in the coding curves that we can take action on? Do we have issues with time of service patient collection amounts? With higher deductible plans, more patient responsibility, we may not just be delaying patient money collection if we don't collect at the time of service. Trying to collect large amounts of money on the back end, we may actually be foregoing some of that money. We also need to look at the impact of denials on all of our reimbursement and how those are impacting the net dollars that we're collecting once we get a denied charge. Scott, you talked about payer contracting and whether or not our payers are complying with their current contracts. Well, to take it a step further, we probably want to look at how payers compare against each other. And do we have an outlier or 2 payers that we don't have the best contracts with, and can we take action on that, and how soon can we take action on that?
Yeah, so I know when I like to look at reimbursement, what I usually start with is what's happening to our charges. What I want to see is kind of a resolution of our charges. What is being turned into actual payments or cash collected? What's a contractual adjustment? And then I bring in what I call non-customary contractuals. And what that is not even necessarily individual payers, but it may be individual codes with certain payers that are just way offline of what others are reimbursing for those. And I look at that and I see that this is kind of a contractual that we're receiving that maybe we could do a little bit better on. I want to bring in bad debt and other adjustments. And then I also want to look at denials and what's sitting out there in open AR, particularly in where it comes to denials. I want to know, when we talk a little bit about denials, I want to know what we can prevent and what we can recover, and really what hasn't been touched so far. And so you can kind of see here, ideally the trend we want to move in is I want to see a lot more of those blocks turning blue rather than other colors, and I want to start working on bringing those other ones down a little bit. So you can see here in a web-based visualization kind of what I talked about before with our charge resolutions, and this one even brings in the charge trend so that you can see the overall volume of the organization and say, are our payments matching the same trend as our charges? One of the things that we look at is the open AR versus the active AR that's just related to denials. And people talk a lot about AR valuation and really what can we expect to receive in terms of cash and what's a kind of a historical contractual, and really what do we think is going to be uncollected. We can go through and we can look at what's outstanding and really come up with a pretty accurate level of what we anticipate turning into cash and contractuals, but that uncollected amount is something that we really want to focus on changing. And again, turning that a little bit blue. And you can see in the biggest area we have is self-pay collection. Well, if we look down in the center at the bottom, we can see our self-pay collections is actually trending in the right direction, but our time of service collections is really flat. That may be an opportunity that we have for some improvement in certain initiatives to get some of those time of service collections so that we can focus on maybe turning some of these other areas where we're struggling in uncollectible amounts and focus our back-end resources on those, because our front-end resources are doing a good job collecting from the patients when they're there.
So, Scott, you talked about looking at your denied charges and how those may be impacting your outstanding AR. So when you're looking at your reimbursement, you really want to start understanding the whole life cycle of a denial, really. So I like this visualization because not only does it give me information about my volumes of current denials, who's denying my charges, what procedure codes are being denied, and what types of denials am I getting? Am I getting registration denials? Am I getting medical denials? Where are my denials coming from? But we take it to another level here because we can start to see what's happening after the denial happens and which codes am I recouping the most money on? Am I expecting to recoup that amount of money, or am I leaving money on the table for those codes? Also, are there specific procedure codes that we should be recouping more on? And is something happening during the life cycle for those particular codes that is causing an issue with reimbursement? So drilling down to that detail, I think, is very helpful.
I think it is very helpful, and really what we've done in this visualization is we brought in a contract profile amount. And that profile amount is actually very beneficial for us to look at because we're not necessarily just looking at the volume of denied charges, but we can actually look at what we would expect to be reimbursed on a clean claim for those individual procedure codes. And when we're looking at it that way, we're getting a really good indication of what our true risk of non-recovery is, or what we can do for maybe preventive efforts on our end to really kind of mitigate the risk of what's out there. So looking at that level of granularity, again, can really help us kind of assess our problem areas and put some new initiatives in place to help us get to where we want to go.
The third area we want to talk about to drive that revenue to the bottom line is maximizing cash flow. So there are lags associated with the revenue cycle that really start before the patient even is seen in the practice. When a patient calls the practice for the first time to try to get an appointment, or if they're being referred by an outside provider, how long is it taking us to get that patient in to be seen? And then the subsequent portions of the revenue cycle, when we start adding the number of days associated with each part of the process, whether it be charge entry or when we get that first insurance payment from the insurance company, that number can add up pretty quickly. So being able to measure all the lags really allows us to understand that entire length of the revenue cycle.
So what you see here is kind of a demonstration of what we're talking about right here, where you look at all of the individual areas of the revenue cycle, and you can see there's a lot of money tied up in that revenue cycle that's not really dropping to our bottom line. And if we can tighten that up, if we can take each of those lags and drop it just by a day, whether it's our providers getting charges in, whether it's the amount of time it sits in the system before it even drops to a claim, or how long it takes our payers to pay us, or how long it takes us to collect the outstanding balance on the back end, tightening that up takes the money out of the revenue cycle and puts it into our bottom line, puts it into the areas where it's usable and something that can be utilized to make our clinical quality better, make our staffing a little bit better, our ratios better, doing the right things for our patients. So let's talk about some ways that we can achieve that, or really what we want to be looking at as far as this goes.
So here's a visualization where we're looking at different measures that are impacting how quickly we're getting money in the door, essentially. So if we look at the chart, the days to payment, you'll see we want most of that money to fall into the 0 to 30 days, maybe falling into the 31 to 60 days. But once we get to the 61 to 90, over 91, or over 120 days, that's where we really want to isolate that and start to see if we have an issue with a payer that we need to focus on to bring those days to payment to a lower number. The next chart I wanted to talk about here was the payer analysis. And we're really measuring how long it's taking us to get our charge into the system and to the payer, and then how long is the payer taking to pay that claim. So we want our bubbles to be really on the lower left-hand corner of this graph. That indicates I'm getting the charge out of the door quickly and my payer is paying me quickly. Now we've got what I would look at as a kind of an outlier here. Medicare, they're paying us quickly, but pretty quickly, 22 days. Well, it's taking me 18 days to get the charge out the door. So if we can cut that down by a few days, that's going to impact our cash in the door in a positive way.
I think it's helpful to look down below as well, Kelly, where you can see the procedure category types of what we're getting in. And right away, one of the things that stands out to me is that our E&M codes are not getting turned in for about 8 days, where our surgical codes are getting in 7 days. There's really no reason our E&M code shouldn't be in within a couple of days. And so trying to better understand why that's occurring, whether it's on the provider side of them not signing off on their notes as quickly as they need to, or whether it's something on the charge entry side where maybe some additional resources need to be allocated, things like that. Really digging in and trying to figure out why these things are going on can really help us, because again, that's probably a pretty quick return on a little bit of investment to drive a little bit of change that goes on there. I think when we look at all of this, really kind of the underlying theme of what we're trying to talk about with cash flow is if you can tighten anything up by even a day, you're going to collect 366 days worth of payments rather than 365 this year. And so anything that we can do to help that process along benefits us. And really, as we've talked about today, what we're really trying to drive at is communication. We want to make sure that information is getting into the hands of the people who need it in order to drive the change that's needed within the organization. And sometimes these changes can be very simple. We want to make sure it's easy for them to read. We want to make sure that they can digest and make judgments on the information very quickly. And we want to give them context so that they know really what's happening good or bad and how far off are they.
And finally, you want to document your assumptions and present those findings to key owners and executives in the process.
Okay. I appreciate your time joining us today. I hope to see you on future PDS webinars. And again, please stay safe during this time. And I hope everyone in your organization is staying safe and doing everything that they can as well. So thank you for your time, and thank you providers for being heroes during this time. Thank you, everyone.
Thank you, everyone.